Okay, Chapter 3, Varcarolis, a biological basis for understanding psychotropic drugs. I think this time I'll go with the key terms and concepts. So you got antagonists, anti-anxiety, anxiolytic drugs, anticholinesterase drugs, atypical antipsychotics, circadian rhythms, conventional antipsychotics, hypnotic, limbic system, lithium, monoamine oxidase inhibitors or MAOIs, mood stabilizers, neurons, neurotransmitter, pharmacodynamics, pharmacokinetics, receptors, reticular activating system or RAS, reuptake, selective serotonin reuptake inhibitors, SSRIs, synapse, therapeutic index, and tricyclic antidepressants. Whether conscious or unconscious, all mental activity has its locus in the brain. This implies that a primary goal of psychiatry is to understand both normal and abnormal mental processes in terms of brain function. Ultimately, we would like to be able to apply this understanding to the treatment of mental disease and the alleviation of mental suffering. Approached in relation to brain function, psychiatric problems are explained and treated in the same way as any other biological problems. Implied in the biological approach to psychiatric illness is the idea that although the origin of psychiatric illness may be related to any number of factors, e.g., genetics, neurodevelopmental factors, drugs, infection, psychosocial experience, there will eventually be an alteration in cerebral function that accounts for the disturbances in the patient's behavior and mental experiences. These physiological alterations are the targets of the psychotropic drugs used to treat mental disease. From a holistic point of view, mental disorders then have neurobiopsychological components that support the efficacy of treating these disorders both pharmacologically and with appropriate psychotherapy. Reversal of these alterations is the goal of the use of psychotropic drugs in the treatment of mental illnesses. During recent years, there has been an explosion of information in this area. Earlier theories, such as the dopamine theory of schizophrenia and the monoamine theory of depression, are currently seen as overly simplistic because a large number of other neurotransmitters, hormones, and co-regulators are now thought to play important and complex roles. The importance of receptor subtypes and the role of these receptors in normal physiology, pathology, and pharmacology are also receiving increasing attention. The goal of this chapter is to relate psychiatric disturbances and the psychotropic drugs used to treat them to normal brain structure and function. We first look at the normal functions of the brain and how they are carried out from an anatomical and physiological perspective. We then review current theories of the neuropsychological basis of various types of emotional and physiological dysfunctions. These theories focus primarily on neurotransmitters and their receptors. Finally, we attempt to relate both the beneficial and the untoward effects of psychiatric drugs to their interaction with various neurotransmitter receptor systems. Although the modern era of the treatment of mental illness with psychotropic drugs extends back to almost half a century, a full understanding of how these drugs improve the symptoms of these illnesses continues to elude investigators. The focus of research is on neurotransmitters, their release from synaptic cells, and their actions on postsynaptic cells, and how psychotropic drugs interact with the physiology of these substances. In recent years, many subtypes of receptors for the various neurotransmitters have been discovered, and long-term changes induced in postsynaptic cells have taken on increased significance. This information is becoming increasingly important for nurses to understand. Such an understanding is particularly crucial for advanced practice psychiatric mental health nurses, who in many states have the authority to write prescriptions. Included in this chapter is an overview of the major drugs used to treat mental disorders and an explanation of how they work. Additional and detailed information regarding adverse and toxic effects, dosage, nursing implications, and teaching tools is presented in the appropriate clinical chapters. See Chapter 12 to 22. Despite new information known about the complex brain functions and neurotransmitters, there is still much to be clarified in understanding the complex ways in which the brain carries out its normal functions, is altered during disease, and is improved by pharmacological intervention. After reading this chapter, you should have a neurobiological framework into which you can place existing as well as future information about mental health or mental illness and its treatment. Structure and function of the brain. Functions and activities of the brain. Regulating behavior and in carrying out mental processes are important, but far from the only responsibilities of the brain. Box 3.1 summarizes some of the major functions and activities of the brain. Because all these brain functions are carried out by similar mechanisms, interactions of neurons, and often in similar locations, it is not surprising that mental disturbances are often associated with alterations in other brain functions, and that the drugs used to treat mental disturbances can also interfere with other activities of the brain. Box 3.1 Functions of the brain. Monitor changes in the external world. Monitor the composition of body fluids. Regulate the contractions of skeletal muscles. Regulate the internal organs. Initiate and regulate the basic drives: hunger, thirst, sex, aggressive, self-protection. Mediate conscious sensation. Store and retrieve memories. Regulate mood, affect, and emotions. Think and perform intellectual functions. Regulate the sleep cycle. Produce and interpret language. Process visual and auditory data. Maintenance of homeostasis. The brain serves as the coordinator and director of the body's response to both internal and external changes. Appropriate responses require a constant monitoring of the environment, interpretation and integration of the incoming information, and control over the appropriate organs of response. The goal of these responses is to maintain homeostasis, and thus to maintain life. Information about the external world is relayed from various sense organs to the brain by the peripheral nerves. This information, which is at first received as gross sensation, light, sound, touch, must ultimately be interpreted: a picture, a train whistle, a hand on the back. Interestingly, a component of major psychiatric disturbance, e.g. schizophrenia, is an alteration of sensory experience. Thus, the patient may experience a sensation that does not originate in the external world. For example, people with schizophrenia may hear voices talking to them, auditory hallucination. The brain not only monitors the external world, but also keeps a close watch on internal functions. Information about blood pressure, body temperature, blood gases, and the chemical composition of the body fluids is continuously received by the brain, signaling to direct the appropriate responses required to maintain homeostasis. To respond to external changes, the brain has control over the skeletal muscles. This control involves the ability not only to initiate contraction, e.g. to contract the biceps and flex the arm, but also to fine-tune and coordinate contraction so a person can, for example, guide the fingers to the correct keys on a piano. Unfortunately, both psychiatric disease and the treatment of psychiatric disease with psychotropic drugs are associated with movement disturbances. It is important to remember that the skeletal muscles controlled by the brain include the diaphragm, essential for breathing, and the muscles of the throat, tongue, and mouth, essential for speech. Thus, drugs that affect brain function can stimulate or depress respiration or lead to slurred speech. Adjustments to changes within the body require that the brain exert control over the various internal organs. For example, if blood pressure drops, the brain must direct the heart to pump more blood and the smooth muscles of the arterioles to constrict. This increase in cardiac output and vasoconstriction allows the body to return blood pressure to its normal level. Regulation of the autonomic nervous system and hormones. The autonomic nervous system and the endocrine system serve as the communication links between the brain and the cardiac muscle, smooth muscle, and glands of which the internal organs are composed. Figure 3.1. If the brain needs to stimulate the heart, it must activate the sympathetic nerves to the sinoatrial node and the ventricular myocardium. If the brain needs to bring about vasoconstriction, it must activate the sympathetic nerves to the smooth muscles of the arterioles. The linkage between the brain and the internal organs that allows for the maintenance of homeostasis may also serve to translate mental disturbances, such as anxiety, into alterations of internal function. For example, anxiety in some people can cause activation of parasympathetic nerves to the digestive tract, leading to hypermotility and diarrhea. Likewise, anxiety can activate the sympathetic nerves to the arterioles, leading to vasoconstriction and hypertension. The brain also exerts influence over the internal organs by regulating hormonal secretions of the pituitary gland, which in turn regulates other glands. In a specific area of the brain, the hypothalamus secretes hormones called releasing factors. These hormones act on the pituitary gland to stimulate or inhibit the synthesis and release of pituitary hormones. Once in the general circulation, they influence various internal activities. An example of this linkage is the release of gonadotropin-releasing hormone by the hypothalamus at the time of puberty. This hormone stimulates the release of two gonadotropins, follicle-stimulating hormone and luteinizing hormone, by the pituitary gland, which consequently activate the ovaries or testes. This linkage may explain why anxiety or depression in some women may lead to disturbances of the menstrual cycle. The relationship between the brain, the pituitary gland, and the adrenal glands is particularly important in normal and abnormal mental function. Specifically, the hypothalamus secretes corticotropin-releasing hormone, CRH, which stimulates the pituitary to release corticotropin, which in turn stimulates the cortex of each adrenal gland to secrete the hormone cortisol. This system is activated as part of the normal response to a variety of mental and physical stresses. Among many other actions, all three hormones, CRH, corticotropin, and cortisol, influence the functions of the nerve cells of the brain. There is considerable evidence that in both anxiety and depression, this system is overactive and does not respond properly to negative feedback. Control of biological drives and behavior. To understand the neurobiological basis of mental disease and its treatment, it is helpful to distinguish between the various types of brain activity that serve as the basis of mental experience and behavior. An understanding of these activities shows where to look for disturbed function and what to hope for in treatment. The brain, for example, is responsible for the basic drives such as sex and hunger that play a strong role in molding behavior. Figure 3.1. The autonomic nervous system has two divisions, the sympathetic and parasympathetic. The sympathetic division is dominant in stress situations such as fear and anger, known as fight or flight response. Disturbances of these drives, that was the end of chart. Disturbances of these drives, e.g. overeating or undereating, loss of sexual interest, can be an indication of an underlying psychiatric disorder such as depression. Cycle of sleep and wakefulness. The entire cycle of sleep and wakefulness, as well as the intensity of alertness while the person is awake, are regulated and coordinated by various regions of the brain. Although we do not fully understand the true homeostatic function of sleep, we know that it is essential for both physiological and psychological well-being. Assessment of sleep patterns is part of what is required to determine a psychiatric diagnosis. Unfortunately, many of the drugs used to treat psychiatric problems interfere with the normal regulation of sleep and alertness. Drugs with a sedative hypnotic effect can blunt the degree to which a person feels alert and focused and can cause drowsiness. The sedative hypnotic effect requires caution in using these drugs while engaging in activities that require a great deal of attention, such as driving a car or operating machinery. One way of minimizing the danger is to take such drugs at night, just before bedtime. Circadian rhythms. The cycle of sleep and wakefulness is only one aspect of circadian rhythms, the fluctuation of various physiological and behavioral parameters over a 24-hour cycle. That's what a circadian rhythm is. Other variations include changes in body temperature, secretion of hormones such as corticotropin and cortisol, and secretions of neurotransmitters such as norepinephrine and serotonin. Both norepinephrine and serotonin are thought to be involved in mood, and daily fluctuations of mood may be related in part to circadian variations in these neurotransmitters. There is evidence that the circadian rhythm of neurotransmitter secretion is altered in psychiatric disorders, particularly in those that involve mood. Conscious mental activity. All aspects of conscious mental experience and sense of self originate from the neurophysiological activity of the brain. Conscious mental activity could be a basic, meandering stream of consciousness flow among thoughts of future responsibilities, memories, fantasy, and so on. Conscious mental activity can also be much more complex when it is applied to problem solving and the interpretation of the external world. Both the random stream of consciousness and the complex problem solving and interpretation of the environment can become distorted in psychiatric illness. Thus, a person with schizophrenia may have chaotic and incoherent speech and thought patterns, a jumble of unrelated words known as word salad. Yummy, yummy. Unconnected phrases and topics known as looseness of association, and delusional interpretations of personal interactions, such as beliefs about people or events that are not supported by data or reality. Memory. An extremely important component of mental activity is memory, the ability to retain and recall past experience. From both an anatomical and physiological perspective, there is thought to be a major difference in the processing of short and long-term memory. This can be seen dramatically in some forms of cognitive mental disorders such as dementia, in which a person has no recall of the events of the previous 8 minutes, but may have vivid recall of events that occurred decades earlier. Social skills. An important and often neglected aspect of brain functioning involves the social skills that make interpersonal relationships possible. In almost all types of mental illness, from mild anxiety to severe schizophrenia, difficulties in interpersonal relationships are important parts of the disorder, and improvements in these relationships are important gauges of progress. The connection between brain activity and social behavior is an area of intense research and is believed to be influenced by a combination of genetic makeup and individual experience. There is evidence that positive reward-based experiential learning and negative avoidance learning may involve different areas of the brain. Cellular composition of the brain. The brain is composed of approximately 1 billion neurons, nerve cells that conduct electrical impulses, as well as other types of cells that surround the neurons. Most functions of the brain, from regulation of blood pressure to the conscious sense of self, are thought to result from the actions of individual neurons and the interconnections between them. Although neurons come in a great variety of shapes and sizes, all carry out the same 3 types of physiological actions. 1. They respond to stimuli. 2. They conduct electrical impulses. 3. They release chemicals called neurotransmitters. An essential feature of neurons is their ability to conduct an electrical impulse from one end of the cell to the other. This electrical impulse consists of a change in membrane permeability that first allows the inward flow of sodium ions and then the outward flow of potassium ions. The inward flow of sodium ions changes the polarity of the membrane from positive on the outside to positive on the inside. Movement of potassium ions out of the cell returns the positive charge to the outside of the cell. Because these electrical charges are self-propagating, a change at one end of the cell is conducted along the membrane until it reaches the other end. The functioning significance of this propagation is that the electrical impulse serves as a means of communication between one part of the body and the other. Once an electrical impulse reaches the end of a neuron, a neurotransmitter is released. A neurotransmitter is a chemical substance that functions as a neuromessenger. Neurotransmitters are released from the axon terminal at the presynaptic neuron on excitation. This neurotransmitter then diffuses across a space or synapse to an adjacent postsynaptic neuron, where it attaches to receptors on the neuron's surface. It is this interaction from one neuron to another by way of neurotransmitter and receptor that allows the activity of one neuron to influence the activity of other neurons. Depending on the chemical structure of the neurotransmitter and the specific type of receptor to which it attaches, the postsynaptic cell will be rendered either more or less likely to initiate an electrical impulse. It is the interaction between neurotransmitter and receptor that is a major target of the drugs used to treat psychiatric disease. Table 3.1 lists important neurotransmitters. Figure 3.2. Activities of neurons. Conduction along a neuron involves the inward movement of sodium ions Na positive, followed by the outward movement of potassium ions Ka positive. When the current reaches the end of the cell, a neurotransmitter is released. The neurotransmitter crosses the synapse and attaches to the receptor on the postsynaptic cell. The attachment of neurotransmitter to receptor either stimulates or inhibits the postsynaptic cell. Some mental illness disorders are associated with an increase or decrease in these neurotransmitters. Table 3.1 shows transmitters and receptors, and I'll just go through it. Dopamine, or also part of monoamines, they're involved in fine muscle movement, involved in integration of emotions and thoughts, involved in decision making, stimulates the hypothalamus to release hormones, sex, thyroid, adrenal, norepinephrine. The level of norepinephrine affects the mood in the brain. Attention and arousal, stimulates synaptic branch or autonomic nervous system for fight or flight in response to stress. Serotonin plays a role in sleep regulation, hunger, mood states, and pain perception. Hormonal activity. Serotonin plays a role in aggression and in sexual behavior. Histamine, H1, H2, involved in alertness, involved in inflammatory response, stimulates gastric secretions. We got amino acids like gamma aminobutyric acid, or GABA. Plays a role in inhibition, reduces aggression, excitation, and anxiety. May play a role in pain perception, anticonvulsant and muscle relaxing properties. May impair cognition and psychomotor functioning. Glutamate, or NMDA, or AMPA, is excitatory. AMPA plays a role in learning and memory. Cholinergics, acetylcholine, ACH, plays a role in learning and memory. Regulates mood, mania, sexual aggression, affects sexual and aggressive behavior, stimulates parasympathetic nervous system. Peptides, neuromodulators. Substance P, or SP, centrally active SP antagonist, has antidepressant and anti-anxiety effects in depression, promotes and reinforces memory, enhances sensitivity to pain receptors to activate. Somatostatin, or SRIF, it altered levels of this associated with cognitive disease. And then finally, for the amino acids, is neurotensin, or NT, endogenous antipsychotic-like properties. And then there's another column that describes all of the actual mental disorders that are associated with each one of those transmitters and their functions. But let y'all go over that. So after attaching to a receptor and exerting its influence on the postsynaptic cell, the neurotransmitter separates from the receptor and is destroyed. The process of neurotransmitter destruction is described in box 3.2. There are two basic mechanisms by which neurotransmitters are destroyed. Some neurotransmitters, e.g. acetylcholine, are destroyed by specific enzymes at the postsynaptic cell. The enzyme that destroys acetylcholine is called acetylcholinesterase. Other neurotransmitters, e.g. norepinephrine, are taken back into the presynaptic cell from which they were originally released by a process called cellular reuptake. Upon their return to these cells, the neurotransmitters are either reused or destroyed by intracellular enzymes. In the case of the monoamine transmitters, e.g. norepinephrine, dopamine, serotonin, the destructive enzyme is called monoamine oxidase, or MAO. As a means of regulating the concentration of neurotransmitters at the postsynaptic receptors, many neurotransmitters exert a feedback inhibition of their own release. This is accomplished by the attachment of neurotransmitters to presynaptic receptors at the synapse, which act to inhibit the further release of neurotransmitters. The concept of a neuron releasing a specific neurotransmitter that stimulates or inhibits a postsynaptic membrane receptor and acts through negative feedback on a presynaptic receptor is an accurate but far from complete picture of the interaction between nerve cells. Researchers have found that in many cases, neurons release more than one chemical at the same time. Neurotransmitters such as norepinephrine or acetylcholine, which have immediate effects on postsynaptic membranes, are often joined by larger molecules, neuropeptides, that they initiate long-term changes in the postsynaptic cells. These changes may involve basic cell function, such as genetic expression, and lead to modifications of cell shape and responsiveness to stimuli. And ultimately, this means that the action of one neuron on another affects not only the immediate response of that neuron, but also its sensitivity to future influence. The long-term implications of this for neural development, normal and abnormal, mental health, and the treatment of psychiatric disease are being investigated. The communication between neurons at a synapse is not unidirectional. Neurotrophic factors are proteins and even simple gases such as carbon monoxide and nitrous oxide that are released by postsynaptic cells and influence the growth, shape, and activity of presynaptic cells. These factors are thought to be particularly important during the development of the fetal brain, guiding the growing brain to form the proper neuronal connections. However, it is now apparent that the brain retains anatomical plasticity throughout life, and that internal and external influences can alter the synaptic network of the brain. The role of altered genetic expression or environmental trauma in the action of these factors and the negative and positive consequences of these changes on mental function in psychiatric disease is an area of much research. The development and responsiveness of neurons is dependent not only on chemicals released by other neurons, but also on chemicals brought to the neurons by the blood, particularly the steroid hormones. Estrogen, testosterone, and cortisol can bind to neurons, where they can cause short and long-term changes in neuronal activity. A clear example of this is seen in the psychosis that can sometimes result from the hypersecretion of cortisol in Cushing's disease, or from the use of prednisone in high doses to treat chronic inflammatory disease. Box 3.2. Box 3.2. Destruction of neurotransmitters. A full explanation of the various ways psychotropic drugs alter neuronal activity requires a brief review of the manner in which neurotransmitters are destroyed after attaching to the receptors. To avoid continuous and prolonged action on the postsynaptic cell, the neurotransmitter is released shortly after attaching to the postsynaptic receptor. Once released, the neurotransmitter is destroyed in one of two ways. One way is the immediate inactivation of the neurotransmitter at the postsynaptic membrane. An example of this method of destruction is the action of the enzyme acetylcholinesterase on the neurotransmitter acetylcholine. Acetylcholinesterase is present at the postsynaptic membrane and destroys acetylcholine shortly after it attaches to nicotinic or muscarinic receptors on the postsynaptic cell. There's a picture there. A second method of neurotransmitter inactivation is a little more complex. After interacting with the postsynaptic receptor, the neurotransmitter is released and taken back into the presynaptic cell, the cell from which it was released. This process, referred to as the reuptake of neurotransmitter, is a common target for drug action. Once inside the presynaptic cell, the neurotransmitter is either recycled or inactivated by an enzyme within the cell. The monoamine transmitters, norepinephrine, dopamine, and serotonin, are all inactivated in this manner by the enzyme monoamine oxidase. Another picture. Look at this second method. You might naturally ask what prevents the enzyme from destroying the neurotransmitter before its release. The answer is that before release, the neurotransmitter is stored within a membrane and is thus protected from the degradative enzyme. After release and reuptake, the neurotransmitter is either destroyed by the enzyme or re-enters the membrane to be used again. End of figure, or chart and box, or whatever. Organization of the brain. Brainstem. The central core of the brainstem regulates the internal organs and is responsible for such vital functions as the regulation of blood gases and the maintenance of blood pressure. The hypothalamus, a small area in the ventral superior portion of the brainstem, plays a vital role in such basic drives as hunger, thirst, and sex. It also serves as a crucial psychosomatic link between higher brain activities, such as thought and emotion, and the function of the internal organs. The brainstem also serves as an initial processing center for sensory information that is then sent on to the cerebral cortex. Through projections of the reticular activating system, or RAS, the brainstem regulates the entire cycle of sleep and wakefulness and the ability of the cerebrum to carry out conscious mental activity. Other ascending pathways, referred to as mesolimbic and mesocortical pathways, seem to play a strong role in modulating the emotional value of sensory material. These pathways project to those areas of the cerebrum collectively known as the limbic system, which play a crucial role in emotional status and psychological function. They use norepinephrine, serotonin, and dopamine as their neurotransmitters. Much attention has been paid to the role of these pathways in normal and abnormal mental activity. For example, it is thought that the release of dopamine from the ventral tegmental pathway plays a role in psychological reward and drug addiction. The neurotransmitters released by these neurons are major targets of the drugs used to treat psychiatric disease. Cerebellum. Located posteriorly to the brainstem, the cerebellum is primarily involved in the regulation of skeletal muscle coordination and contraction and the maintenance of equilibrium, figure 3.3. It plays a crucial role in coordinating contractions so that movement is accomplished in a smooth and directed manner. Cerebrum. The human brainstem and cerebellum are similar in both structure and function to these same structures in other mammals. The development of a much larger and more elaborate cerebrum is what distinguishes human beings from the rest of the animal kingdom. Figure 3.3, the functions of the brainstem. There's a large picture of the brain there. The cerebrum, situated on top of and surrounding the brainstem, is responsible for mental activities and a conscious sense of being. The cerebrum is responsible for our conscious perception of the external world and our own body, emotional status, memory, and control of skeletal muscles that allow willful direction of movement. It is also responsible for language and the ability to communicate. The cerebrum consists of surface and deep areas of integrating gray matter, the cerebral cortex and basal ganglia, and the connecting tracts of white matter that link these areas with each other and the rest of the nervous system. The cerebral cortex, which forms the outer layer of the brain, is responsible for conscious sensation and the initiation of movement. Specific areas of the cortex are responsible for specific sensations. The parietal cortex for touch, the temporal cortex for sound, the occipital cortex for vision, and so on. The initiation of skeletal muscle contraction is controlled by a specific area of the frontal cortex. All areas of the cortex are interconnected to enable an appropriate picture of the world to be formed and, if necessary, linked to a proper response. Figure 3.4. Specialized areas of the cerebral cortex are responsible for language in both its sensory and motor aspects. Sensory language functions include the ability to read, understand spoken language, and know the names of objects perceived by the senses. Motor functions involve the physical ability to use some muscles properly for speech and writing. In both neurological and psychological dysfunction, the use of language may become compromised or distorted. The change in linguistic ability may be a factor in determining a diagnosis. In addition to the gray matter forming the surface of the cerebrum, there are pockets of integrating gray matter deep within the cerebrum. Some of these, the basal ganglia, are involved in the regulation of movement. Others, the amygdala and hippocampus, are involved in emotions, learning, memory, and basic drives. Significantly, there is an overlap of these various areas both anatomically and in the types of neurotransmitters employed. One consequence is that drugs used to treat emotional disturbances may cause movement disorders, and drugs used to treat movement disorders may cause emotional changes. Visualizing the brain. A variety of non-invasive image techniques is used to visualize brain structure, functions, and metabolic activity. Table 3.2. Table 3.2 identifies some common brain imaging techniques and preliminary findings as they relate to psychiatry. There are basically two types of neuroimaging techniques, structural and functional. Structural imaging techniques, e.g. computer topography, CT, and magnetic resonance imaging, MRI, identify gross anatomical changes in the brain. Functional imaging techniques, e.g. positron emission tomography, a PET scan, and single photon emission computed tomography, SPECT, SPECT, reveal physiological activity in the brain as described in Table 3.2. Table 3.2, common brain imaging techniques. Structural, show gross anatomical detail of brain structures. So the technique would be computer tomography, CT scan. Description is series of X-ray images are taken of the brain, and computer analysis produces slices, providing a precise 3D-like reconstruction of each segment. Uses: it can detect lesions, abrasions, areas of infarct, and aneurysm. Psychiatric relevance and preliminary findings of a CT: schizophrenia, cortical atrophy, third ventricular enlargement, cognitive disorders, abnormalities. Then there's the magnetic resonance imaging, MRI. It is a magnetic field that's applied to the brain. Nuclei of hydrogen atoms absorb and emit radio waves that are analyzed by computer, providing 3D visualization of the brain structure in sectional images. It can detect brain edema, ischemia, infection, neoplasm, and trauma. Mental disorders associated you can find this with the MRI would be schizophrenia, enlarged ventricles, reduction in temporal lobe, and prefrontal lobe. You can find schizophrenia, and you would find schizophrenia by seeing enlarged ventricles and reduction in temporal lobe and prefrontal lobe. That's what I meant. Okay, functional magnetic resonance imaging, fMRI. It's a functional imaging approach that avoids exposure to ionizing radiation. Same as MRI on both of the other things. Functional shows some this is the functional side, and this shows some activity of the brain. Okay, so positron emission tomography, PET scan, is a radioactive substance called a tracer injected. It travels to the brain and shows up as bright spots on the scan. Data collected by detectors are relayed to the computer, which produces images of the activity and 3D visualization of the central nervous system. It can detect oxygen utilization, glucose metabolism, blood flow, and neurotransmitter/receptor interaction. In schizophrenia, you'll see increased D2 and D3 receptors in caudate nucleus, abnormalities in limbic system, and then to detect mood disorders, you'll see abnormalities in temporal lobes. In adult ADHD, you'll see decreased utilization of glucose. And then there's the SPECT scan, the single photon emission computed tomography, and it's similar to the PET but uses radionuclides that emit gamma radiation or photons, measures various aspects of the brain functioning, and provides images of multiple layers of the CNS, same as the PET. It can detect circulation of cerebral spinal fluid, and it also has a lot of similar functions to the PET. Same thing with diagnosing mental disorders. So PET scans are particularly useful in identifying physiological and biochemical changes as they occur in living tissue. Usually a radioactive tag is used to trace compounds such as glucose. In the brain, glucose use is related to functional activity in certain areas. For example, in patients with schizophrenia, PET scans may show a decreased use of glucose in the frontal lobes of untreated individuals. Figure 3.5 shows lower brain activity in the frontal lobe of a twin diagnosed with schizophrenia than in the asymptomatic twin. The area affected in the frontal cortex of the twin with schizophrenia is an area associated with reasoning skills, which are greatly impaired in people with schizophrenia. Scans such as these suggest a location in the frontal cortex as the site of functional impairment in people with schizophrenia. In people with obsessive-compulsive disorder, OCD, PET scans show that brain metabolism is increased in certain areas of the frontal cortex. Figure 3.6 shows increased brain metabolism in an individual with OCD compared with a control, suggesting altered brain function in people with OCD. PET scans of individuals with depression show decreased brain activity in the prefrontal cortex. Figure 3.7 shows the result of a PET scan taken after a form of radioactively tagged glucose was used as a tracer to visualize brain activity. The patient with depression shows reduced brain activity compared with the control. Finally, Figure 3.8 shows 3 views of a PET scan of the brain of a patient with Alzheimer's disease. Modern imaging techniques have also become important tools in assessing molecular changes in mental disease and marking the receptor sites of drug action. From a psychiatric perspective, we would like to be able to understand where in the brain the various components of psychological activity take place and what types of neurotransmitters and receptors underlie this activity physiologically. Currently, our understanding of both of these questions is far from complete. However, it is thought that the limbic system, a group of structures that includes parts of the frontal cortex, the basal ganglia, and the brainstem, is a major locus of psychological activity. Within these areas, the monoamine transmitters, norepinephrine, dopamine, and serotonin, the amino acid transmitters, glutamate and gamma aminobutyric acid, GABA, and the neuropeptides, CRH and endorphin, as well as acetylcholine, play a major role. Alterations in these areas appear to form the basis of psychiatric disease and are the target for pharmacological treatment. Then there's a bunch of figures from the PET scans. Disturbances of mental function. Most occurrences of mental dysfunction are of unknown origin. Among known causes are drugs, e.g. lysergic acid diethylamide, LSD, long-term use of prednisone, excess levels of hormones, e.g. thyroxine, cortisol, infection, e.g. encephalitis, acquired immunodeficiency syndrome, AIDS, and physical trauma. Even when the cause is known, however, the link between the causative factor and the mental dysfunction is far from understood. There is often a genetic predisposition for psychiatric disorders. The incidence of both thought and mood disorders is higher in relatives of people with these disorders than in the general population. There is also a strong concordance among identical twins, even when they are raised apart. Concordance refers to how often one twin will be affected by the same illness as the other. Psychosocial stress, either in the family or of origin or in contacts with society at large, increases the likelihood of mental problems. as does physical distress or physical disease. Genetics and environment interact in complex ways so that people are better able to cope with stress than others. Researchers ultimately want to be able to understand mental dysfunction in terms of altered activity of neurons in specific areas of the brain. The hope is that such an understanding will lead to better treatments and possible prevention of mental disorders. Current interest is focused on certain neurotransmitters and their receptors, particularly in the limbic system, which links the frontal cortex, basal ganglia, and upper brainstem. As mentioned earlier, the neurotransmitters that have been most consistently linked to mental activity are norepinephrine, dopamine, serotonin, GABA, and glutamate. Although the underlying physiology is complex, it is thought that a deficiency of norepinephrine or serotonin, or both, may serve as the biological basis of depression. Figure 3.9 shows that an insufficient degree of transmission may be due to a deficient release of neurotransmitters by the presynaptic cell, or to a loss of the ability of postsynaptic cells to respond to the neurotransmitters. Changes in neurotransmitter release and receptor response can be both a cause and a consequence of intracellular changes in the neurons involved. Thought disorders such as schizophrenia are associated physiologically with excess transmission of neurotransmitter dopamine, among other changes. As illustrated in Figure 3.10, this may be due to either an excess release of neurotransmitter or an increase in receptor responsiveness. The neurotransmitter gamma-aminobutyric acid, GABA, seems to play a role in modulating neuronal excitability and anxiety. Not surprisingly, many anti-anxiety or anxiolytic drugs act by increasing the effectiveness of this neurotransmitter. This is accomplished primarily by increasing receptor responsiveness. It is important to keep in mind that the various areas of the brain are interconnected structurally and functionally by a vast network of neurons. This network serves to integrate the many and varied activities of the brain. A limited number of neurotransmitters are used in the brain, and thus a particular neurotransmitter is often used by different neurons to carry out quite different activities. For example, dopamine is used by neurons involved in not only thought processes, but also the regulation of movement. Alterations in neurotransmitter activity due to a mental disturbance or to the drugs used to treat the disturbance can affect more than one area of the brain activity. In other words, alterations in mental status, whether arising from disease or from medication, are often accompanied by changes in basic drives, sleep patterns, body movement, and autonomic functions. Mechanisms of action of psychotropic drugs. When studying drugs, it is important to keep in mind the concepts of pharmacodynamics and pharmacokinetics. Pharmacodynamics refers to the biochemical and physiological effects of drugs on the body, which include the mechanisms of drug action and its effects. Pharmacokinetics refers to the actions of the body on the drug. How is the drug absorbed into the blood? How is it transformed in the liver? How is it distributed in the body? How is it excreted by the kidney? Pharmacokinetics determine the blood level of a drug, and it's used to guide the dosage schedule. It is also used to determine the type and amount of drug used in cases of liver and kidney disease. The processes of pharmacokinetics and pharmacodynamics play an extensive role in how genetic factors give rise to inter-individual and cross-ethnic variations in drug response. The Considering Culture box discusses how the area of pharmacogenetics may influence the way healthcare providers tailor their prescriptions for patients. Considering Culture box, pharmacogenetics. Pharmacogenetics explains how genetic variation leads to clinical differences in drug response of different individuals and ethnic groups. Variation of drug metabolism via the CYP450 enzymes leads to significant differences in psychotropic drug concentrations between those who metabolize drugs poorly and those who metabolize drugs extensively. Metabolism of many psychotropic drugs, e.g. risperidol, involves the CYP450 2D6 enzymes. Poor metabolizers of these enzymes, about 5% to 10% of Caucasians, may experience more side effects from higher drug levels. About 20 to 30% of Asian subgroups are poor metabolizers of CYP450 2C119 or 2C19 enzymes and have reduced clearance of many of the psychotropic drugs compared to Caucasians. Many factors influence adherence with the medical regimen in all groups of people, but individuals from some ethnic and cultural groups have even greater adherence issues for a variety of reasons. For example, cultural and ethnic beliefs surrounding mental illness, attitudes toward the mental health system, and the cultural practices of an ethnic group all impact greatly a patient's degree of engagement with and adherence to the medical regimen. This topic is discussed more fully in Chapter 6. End of box. Many drugs are transformed by the liver into active metabolites, chemicals which themselves have pharmacological actions. This knowledge is used by researchers in designing new drugs that make use of the body's own mechanisms to activate a chemical for pharmacological use. An ideal psychiatric drug would relieve the mental disturbance of the patient without inducing additional cerebral, mental, or somatic physical effects. Unfortunately, in psychopharmacology, as in most areas of pharmacology, there are no drugs that are both fully effective and free of undesired side effects. Researchers are working toward developing medications that target the symptoms while producing no or few side effects. Because all activities of the brain involve actions of neurons, neurotransmitters, and receptors, these are the targets of pharmacological interventions. Most psychotropic drugs act by either increasing or decreasing the activity of certain neurotransmitter receptor systems. It is generally agreed that different neurotransmitter receptor systems are dysfunctional in persons with different psychiatric conditions. These differences offer more specific targets for drug action. In fact, much of what is known about the relationship between specific neurotransmitters and specific disturbances has been derived from knowledge of the pharmacology of the drugs used to treat these conditions. For example, most agents that were effective in reducing the delusions and hallucinations of schizophrenia blocked the D2 dopamine receptors. It was concluded that delusions and hallucinations result from overactivity of dopamine at these receptors. Anti-anxiety and hypnotic drugs. Gamma-aminobutyric acid, GABA, is the major inhibitory or calming neurotransmitter in the central nervous system, CNS. There are three major types of GABA receptors: GABA A, GABA B, and GABA C receptors. The various subtypes of GABA A receptors are the targets of benzodiazepines, barbiturates, and alcohol. Drugs that enhance GABA A receptors exert a sedative, hypnotic action on brain function. The most commonly used anti-anxiety agents are the benzodiazepines, and more recently, the antidepressants. Selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors. Benzodiazepines. Benzodiazepines potentiate or promote the activity of GABA by binding to a specific receptor on the GABA A receptor complex. This binding result in increased frequency of chloride channel opening causes membrane hyperpolarization, which inhibits cellular excitation. If cellular excitation is decreased, the result is a calming effect. Figure 311 shows that benzodiazepines such as diazepam, Valium, clonazepam, Klonopin, and alprazolam, Xanax, bind to GABA A receptors with different alpha subunits. Alpha 2 subunits may be the most important for decreasing anxiety. And figure 311 shows how benzos work. Since benzodiazepines are non-selective for GABA A receptors with different alpha subunits, all can cause sedation at higher therapeutic doses. There are 5 benzodiazepines approved by the U.S. Food and Drug Administration, FDA, for treatment of insomnia: flurazepam or Dalmane, temazepam, Restoril, triazolam, Halcyon, Estozalam, Prosom, and Quazepam, Doral, with a predominantly hypnotic or sleep-inducing effect. Other benzodiazepines, such as lorazepam or Ativan and alprazolam, Xanax, reduce anxiety without being as soporific, sleep-producing, at lower therapeutic doses. The fact that the benzodiazepines potentiate the ability of GABA to inhibit neurons probably accounts for their efficacy as anticonvulsants and for their ability to reduce the neuronal overexcitement of alcohol withdrawal. When used alone, even at higher doses, these drugs rarely inhibit the brain to the degree that respiratory depression, coma, and death result. However, when combined with other central nervous system depressants, such as alcohol, opiates, or tricyclic antidepressants, TCAs, the inhibitory actions of the benzodiazepines can lead to life-threatening CNS depressions. Any drug that inhibits electrical activity in the brain can interfere with motor ability, attention, and judgment. A patient taking benzodiazepines must be cautioned about engaging in activities that could be dangerous if reflexes and attention are impaired, including specialized activities such as working in construction and more common activities such as driving a car. In older adults, the use of benzodiazepines may contribute to falls and broken bones. Ataxia is a common side effect secondary to the abundance of GABA receptors in the cerebellum. Short-acting sedative hypnotic sleep agents. A newer class of hypnotics termed the Z-hypnotics includes zolpidem, Ambien, Zaleplon, Sonata, and eszopicolone, Lunesta. They have sedative effects without the anti-anxiety, anticonvulsant, or muscle relaxant effects of benzodiazepines, and they demonstrate selectively for GABA A receptors containing alpha-1 subunits. The drug's affinity to alpha-1 subunits has the potential for amnesiac and ataxic unsteadiness side effects, and the onset of action is faster than that of most benzodiazepines. It is important to inform patients taking non-benzodiazepine hypnotic agents about the quick onset and advise them to take the drug when they are ready to go to sleep. Most of these drugs have short half-lives, which determine the duration of action. Zopiclone has the longest duration of action, an average of 7 to 8 hours of sleep per therapeutic dose. The half-lives of zolpidem and zaleplon are much shorter. Zopiclone also has the unique side effect of an unpleasant taste upon awakening, although tolerance and dependence are reportedly less than with benzodiazepines. All of the benzodiazepines and Z-hypnotics are categorized as Schedule C-4 by the U.S. Drug Enforcement Administration, DEA. Melatonin receptor agonists. Melatonin is a hormone that is only excreted at night as part of the normal circadian rhythm. Ramelteon, or Rozarem, the latest FDA-approved hypnotic agent, is a melatonin receptor agonist and acts much the same way as endogenous, naturally occurring melatonin. It has a high selectivity and potency at the melatonin 1 receptor site, thought to regulate sleepiness, and at the melatonin 2 receptor site, thought to regulate circadian rhythms. This is the only hypnotic medication approved for the treatment of insomnia that is not classified as a scheduled substance or one having abuse potential by the DEA. Side effects include headache and dizziness. Although most of the hypnotics are indicated for short-term use, the two newest hypnotics on the U.S. market, Azopiclone and Ramelteon, are not registered to short-term use on the package labeling. Restricted to short-term use on the package labeling. Long-term use of Ramelteon above therapeutic doses can lead to increased prolactin and associated side effects, sexual dysfunction. Buspirone. Buspirone, or Buspar, is a drug that reduces anxiety. Try that again. Buspirone, or Buspar, is a drug that reduces anxiety without having strong sedative hypnotic properties. Because this agent does not leave the patient sleepy or sluggish, it is often much better tolerated than benzodiazepines. It is not a CNS depressant and thus does not have as great danger of interaction with other CNS depressants such as alcohol. Also, there is not the potential for addiction that exists with benzodiazepines. Although at present the mechanism of action of buspirone is not clearly understood, one possibility is illustrated in Figure 312. Buspirone seems to act as a partial serotonin agonist. It also has a moderate affinity for dopamine 2 receptors. Side effects include headache, dizziness, lightheadedness, nausea, and insomnia. Refer to Chapter 12 on anxiety disorders for discussion of the adverse reactions, dosages, nursing implications, and patient and family teaching for the anti-anxiety drugs. Treating anxiety disorders with antidepressants. The symptoms, neurotransmitters, and circuits associated with anxiety disorders overlap extensively with those of depressive disorders. See Chapter 13. And many antidepressants have proven to be effective treatments for anxiety disorders. SSRIs are often used to treat OCD, social anxiety disorder, generalized anxiety disorder, panic disorder, and post-traumatic stress disorder. Venlafaxine, Effexor XR, is used to treat generalized anxiety disorder, social anxiety disorder, and panic disorder. Duloxetine, or Cymbalta, has recently received FDA approval for GAD, or general anxiety disorder. Figure 312 shows the proposed action of buspirone. Antidepressant drugs. Our understanding of the neurophysiological basis of mood disorders is far from complete. However, a great deal of evidence seems to indicate that the neurotransmitters norepinephrine and serotonin play a major role in regulating mood. It is thought that a transmission deficiency of one or both of these monoamines within the limbic system underlies depression. One piece of evidence is that all the drugs that show efficacy in the treatment of depression increase the synaptic level of one or both of these neurotransmitters. Figure 313 identifies the side effects of specific neurotransmitters being blocked or activated. Figure 314 illustrates the normal release, reuptake, and destruction of the monoamine neurotransmitters. A grasp of this underlying physiology is essential for understanding the mechanisms by which the antidepressant drugs are thought to act. 3 hypotheses of antidepressants' mechanism of action. 1. The monoamine hypothesis of depression suggests that there is a deficiency in one or more of the 3 neurotransmitters, serotonin, norepinephrine, or dopamine. The theory is that increasing these neurotransmitters alleviates depression. 2. The monoamine receptor hypothesis of depression. This suggests that low levels of neurotransmitters cause postsynaptic receptors to be upregulated, increased in sensitivity or number. Increasing neurotransmitters by antidepressants results in downregulation or desensitization of key neurotransmitter receptors. Delayed length of time for downregulation may answer the question of why it takes so long for antidepressants to work, especially if they rapidly increase neurotransmitters. 3. Another hypothesis for the mechanism of antidepressant drugs is that they increase production of neurotrophic factors that with prolonged use of antidepressants. These factors regulate the survival of neurons and enhance the sprouting of axons to form new synaptic connections. Figure 313 shows possible effects of receptor binding of the antidepressant medications. Figure 314, normal release, reuptake, and destruction of monoamine neurotransmitters. Good stuff, good stuff. Tricyclic antidepressants, or TCAs. Tricyclic and heterocyclic antidepressants were widely used prior to the development of SSRIs. TCAs are no longer considered first-line treatment for depression since they have more side effects, take longer to reach an optimal dose, and are far more lethal in overdose. The tricyclic antidepressants, TCAs, are thought to act primarily by blocking the reuptake of norepinephrine for the secondary amines, e.g. nortriptyline or Pamelor, and both norepinephrine and serotonin for the tertiary amines, e.g. amitriptyline, Adavil, imipramine, which is also tofranil. As shown in Figure 315, this blockage prevents norepinephrine from coming into contact with its degrading enzyme, MAO, and thus increases the level of norepinephrine at the synapse. Similarly, the tertiary TCAs block the reuptake and destruction of serotonin and increase the synaptic level of this neurotransmitter. Visit the Evolve website for more. Okay. To varying degrees, many of the tricyclic drugs also block the muscarine receptors that normally bind acetylcholine. This blockage leads to typical anticholinergic effects, such as blurred vision, dry mouth, tachycardia, urinary retention, and constipation. These adverse effects can be troubling to patients and limit their adherence with the regimen. Depending on the individual drug, these agents can also block histamine 1 receptors in the brain. Blockage of these receptors by any drug causes sedation and drowsiness, an unwelcome side effect in daily use. See Figure 313. People taking the TCAs often have adherence issues because of the adverse reactions. TCA overdose can be fatal, secondary to cardiac conduction disturbances from excessive sodium channel blockade. SSRI inhibitors, or SSRIs. As the name implies, the selective serotonin reuptake inhibitors, SSRIs, such as fluoxetine, Prozac, sertraline, Zoloft, paroxetine, Paxil, citalopram, Celexa, Citalopram, Lexapro, and fluoxetine, Lovox, preferentially block the reuptake and thus the destruction of serotonin. SSRIs as a group have less ability to block the muscarinic and histamine 1 receptors than do TCAs. As a result of their more selective action, they seem to show comparable efficacy without eliciting the anticholinergic and sedating side effects that limit patients' adherence. However, SSRIs have other side effects resulting from stimulation of a variety of serotonin receptors. Stimulation of various serotonin receptors may inhibit the spinal reflexes of orgasm, lead to apathy and low libido, and may cause nausea or vomiting. Visit the Evolve website for more detailed explanation of SSRIs work. Figure 315 shows how tricyclic antidepressants block the reuptake of norepinephrine. Figure 316 shows how the selective serotonin reuptake inhibitors work. Serotonin norepinephrine reuptake inhibitors. Serotonin norepinephrine reuptake inhibitors, SNRIs, are medications that increase both serotonin and norepinephrine. Venlafaxine, or Effexor, is more of a serotonergic agent at low therapeutic doses, but norepinephrine reuptake blockade occurs at higher doses, leading to the dual SNRI action. Hypertension induced in about 5% of patients is a dose-dependent effect based on norepinephrine reuptake blockade. Doses higher than 150 milligrams a day can increase systolic blood pressure about 7 to 10 millimeters per mmHg. Duloxetine or Cymbalta is an SNRI indicated for both depression and diabetic peripheral neuropathy. Like the TCAs, many of the SNRIs also have a therapeutic effect on neuropathic pain. The common underlying mechanism of neuropathic pain is nerve injury or dysfunction. The mechanisms by which TCAs and SNRIs reduce neuropathic pain is through activation of descending norepinephrine and serotonin pathways to the spinal cord, thereby limiting pain signals ascending to the brain. Serotonin norepinephrine disinhibitors. The class of drugs described as serotonin norepinephrine disinhibitors, SNDIs, is represented by only one drug, mirtazapine, Remeron, which increases norepinephrine and serotonin transmission by antagonizing or blocking presynaptic alpha-2 noradrenergic receptors. Mirtazapine offers both anti-anxiety and antidepressant effects, with minimal sexual dysfunction secondary to serotonin blockade. This antidepressant is particularly suited for the patient with nausea because it is an antiemetic via serotonin blockade. The most common side effects of sedation are sedation and weight gain. Monoamine oxidase inhibitors, or MAOIs. Monoamine oxidase inhibitors, MAOIs, are a group of antidepressant drugs that illustrate the principle that drugs can have a desired and beneficial effect in the brain, while at the same time having possibly dangerous effects elsewhere in the body. To understand the action of these drugs, keep in mind the following definitions. Monoamines, a type of organic compound, includes the neurotransmitters norepinephrine, epinephrine, dopamine, and serotonin, as well as many different food substances and drugs. Monoamine oxidase, MAO, an enzyme that destroys monoamines. Monoamine oxidase inhibitors, MAOIs, drugs that prevent the destruction of monoamines by inhibiting the action of MAO. The monoamine neurotransmitters, as well as any monoamine food substance or drug, are degraded or destroyed by the enzyme MAO, which is located in neurons in the liver. Antidepressant drugs such as phenelzine, Nardil, tranylcypromine, Parnate, selegiline, MSAM, are MAOIs that act by inhibiting the enzyme and interfering with the destruction of the monoamine neurotransmitters. This in turn increases the synaptic level of the neurotransmitters and makes possible the antidepressant effects of these drugs. Figure 317. The use of MAO inhibiting drugs is complicated by the fact that MAO is also present in the liver and is responsible for degrading monoamine substances that enter the body via food or drugs. Of particular importance is the monoamine tyramine, which is present in many food substances such as aged cheeses, pickled or smoked fish, and wine. Tyramine poses a threat of hypertensive crisis because it can produce significant vasoconstriction and thus an elevation in blood pressure. If allowed to circulate freely in the blood, Normally, this does not happen because tyramine is destroyed by MAO as it passes through the liver before entering the general blood circulation. However, in the presence of MAOIs, tyramine is not destroyed by the liver and can cause serious, even life-threatening hypertensive crisis. Figure 317 shows the blocking of monoamine oxidase by inhibiting agents, which prevents the breakdown of monoamine by MAO. A substantial number of drugs are chemically monoamines. The dosages of these drugs are determined by the rate at which they are destroyed by MAO in the liver. In a patient taking MAOIs, the blood level of monoamine drugs can reach high levels and cause serious toxicity. Thus, MAOIs are contraindicated with concurrent use of any other antidepressant and sympathomimetic drugs. Concurrent use with some over-the-counter products with sympathomimetic properties, e.g. oral decongestants, should be avoided. Because of the dangers that result from inhibition of hepatic MAO, patients taking MAOIs must be given a list of foods high in tyramine and drugs that must be avoided. Chapter 13 discusses the treatment of depression and contains a list of forbidden foods and foods to be eaten in moderation, along with nursing measures and instructions for patient teaching. Other antidepressants. Bupropion is an effective antidepressant, also called Wellbutrin, that is also used for smoking cessation. Zyban. It seems to act as a dopamine norepinephrine reuptake inhibitor. It also inhibits nicotinic acetylcholine receptors to reduce the addictive action of nicotine. Since bupropion has no serotonin action, it does not cause sexual side effects. Side effects include insomnia, tremor, anorexia, and weight loss. Bupropion is contraindicated in patients with a seizure disorder, in patients with a current or prior diagnosis of bulimia or anorexia nervosa, and in patients undergoing abrupt discontinuation of alcohol or sedatives, including benzodiazepines, owing to the additive seizure risk. Trazodone is not a first choice for antidepressant treatment, but it is often given along with another agent because sedation, one of the common side effects, helps with insomnia. Its antidepressant effects are only seen at high therapeutic doses. The common side effects are sedation and orthostasis. Trazodone's sedative effect is from potent histamine 1 blockade. Orthostasis is from A1 adrenergic blockade. Its potent A1 blockade with minimal anticholinergic effects can lead to another rare side effect, priapism, painful prolonged penile erection. Ouch. Mood stabilizers. Lithium. Although the efficacy of lithium as a mood stabilizer in patients with bipolar/manic depressive disorder has been established for many years, its mechanism of action is still far from understood. As a positively charged ion similar in structure to sodium and potassium, lithium may well act by affecting electrical conductivity in neurons. As discussed earlier, an electrical impulse consists of the inward depolarizing flow of sodium followed by an outward repolarizing flow of potassium. These electrical charges are propagated along the neuron. If they are initiated at one end of the neuron, they will pass to the other end. Once they reach the end of a neuron, a neurotransmitter is released. It may be that an overexcitement of neurons in the brain underlies bipolar disorder, and that lithium interacts in some complex way with sodium and potassium at the cell membrane to stabilize electrical activity. Also, lithium may reduce the excitatory neurotransmitter glutamate and exert an anti-manic effect. The other proposed mechanisms by which lithium works to regulate mood include the non-competitive inhibition of the enzyme inositol monophosphatase. Inhibition of serotonin autoreceptors by lithium is more related to the agent's antidepressant effects than its anti-manic effects. While we do not know exactly how lithium works, we are certain that its influence on electrical conductivity results in adverse effects and toxicity. By altering electrical conductivity, lithium presents a potential threat to all body functions, regulated by electrical currents. Foremost among these functions is cardiac contraction. Lithium can induce, although not commonly, sinus bradycardia. Extreme alterations of cerebral conductivity with overdose can lead to convulsions. Alteration in nerve and muscle conduction can commonly lead to tremor at therapeutic doses or more extreme motor dysfunction with overdose. The fact that sodium and potassium play a strong role in regulating fluid balance and the distribution of fluid in various body compartments explains the disturbances in fluid balance that can be caused by lithium. These include polyuria, the output of large volumes of urine, and edema, the accumulation of fluid in the interstitial space. Long-term use of lithium can cause hypothyroidism in some patients by interfering with iodine molecules and affecting formation and conversion to the active form of thyroid hormone triiodothyronine T3. In addition, hyponatremia can increase the risk of lithium toxicity because increased renal reabsorption of sodium leads to increased reabsorption of lithium as well. Primarily because of its effects on electrical conductivity, lithium has a low therapeutic index. The therapeutic index represents the ratio of the lethal dose to the effective dose, and is a measure of overall drug safety in regards to the possibility of overdose or toxicity. It could be expressed as therapeutic index equals median lethal dose divided by median effective dose. A low therapeutic index means the blood level of a drug that can cause death is not far above the blood level required for drug effectiveness. This mandates that the blood level of lithium be monitored on a regular basis to be sure the drug is not accumulating and rising up to dangerous levels. Table 3.3 lists some of the adverse and toxic effects of lithium. Chapter 14 considers lithium treatment in more depth and discusses specific dose-related adverse and toxic effects, nursing implications, and the patient teaching plan. Table 3.3 Adverse Toxic Effects of Lithium. The nervous and muscular system, it can cause tremor, ataxia, confusion, convulsions. Digestive system, nausea, vomiting, diarrhea. Cardiac, arrhythmias. Fluid and electrolyte, polyuria, polydipsia, and edema. Endocrine, goiter, and hypothyroidism. Anticonvulsant drugs. Valproate, available as divalproex sodium or Depakote, and valproic acid, Depakine, carbamazepine, Tegretol, and lamotrigine, lamictal, have demonstrated efficacy in the treatment of bipolar disorders. Their anticonvulsant properties derive from the alteration of electrical conductivity in membranes. In particular, they reduce the firing rate of very high-frequency neurons in the brain. It is possible that this membrane stabilizing effect accounts for the ability of these drugs to reduce the mood swings that occur in patients with bipolar disorders. Other proposed mechanisms as mood stabilizers are glutamate agonists and GABA agonists. Valproate or Depakote or Depakine is structurally different from other anticonvulsants and psychiatric drugs that show efficacy in the treatment of bipolar disorder. Divalproex is recommended for mixed episodes and has been found useful for rapid cycling. Common side effects include tremor, weight gain, and sedation. Occasional serious side effects are thrombocytopenia, pancreatitis, hepatic failure, and birth defects. Baseline levels are measured for liver function indicators and complete blood count, CBC, before an individual is started on this medication, and measurements are repeated periodically. In addition, the therapeutic blood level of the drug is monitored. Carbamazepine or Tegretol is useful in preventing mania and during episodes of acute mania. It reduces the firing rate of overexcited neurons by reducing the activity of sodium channels. Common side effects include anticholinergic side effects, e.g. dry mouth, constipation, urinary retention, blurred vision, orthostasis, sedation, and ataxia. Rash may occur in 10% of patients. Recommended baseline laboratory work includes liver function tests, CBC, electrocardiogram, and electrolyte levels. Blood levels are monitored to avoid toxicity greater than 12 micrograms per milliliter. But there is no established therapeutic blood levels for carbamazepine in the treatment of bipolar disorder. Lamotrigine, lamictal, is approved by the FDA for maintenance therapy of bipolar disorder, but it is not effective in acute mania. Lamotrigine works well in treating the depression of bipolar disorder with less incidence of switching the patient into mania than antidepressants. It modulates the release of glutamate and aspartate. Patients should promptly report any rashes, which could be a sign of the life-threatening Stevens-Johnson syndrome, which is where your skin peels off. This can be minimized by slow titration to therapeutic doses. Other anticonvulsants. Other anticonvulsants used in mood stabilizers are gabapentin, or Neurontin, topiramate, or Topamax, and oxcarbazepine, or Trileptal. None of them have FDA approval as mood stabilizers, and studies have not provided strong support for their use as primary treatments for bipolar disorder. Antipsychotic medications and anti-anxiety medications, such as clonazepam or Klonopin, are used for their calming effects during mania. Chapter 14 offers a more detailed discussion of these medications. Antipsychotic drugs. Conventional antipsychotics. First-generation antipsychotic drugs, or conventional antipsychotics, also called typical or standard, are strong antagonists at the D2 dopamine receptors. By binding to these receptors and blocking the attachment of dopamine, they reduce dopaminergic transmission. It has been postulated that an overactivity of the dopamine system in certain areas of the mesolimbic system may be responsible for at least some of the symptoms of schizophrenia. Thus, blockage of dopamine may reduce these symptoms. This is thought to be particularly true of the positive symptoms of schizophrenia, such as delusions, e.g. paranoid and grandiose ideas, and hallucinations, e.g. hearing or seeing things not present in reality. Chapter 15 presents a more detailed discussion of schizophrenia and its symptoms. These drugs are also antagonists to varying degrees of the muscarinic receptors for acetylcholine, A1, adrenergic receptors for norepinephrine, and histamine 1 receptors. Although it is unclear if this antagonism plays a role in the beneficial effect of the drugs, it is certain that antagonism is responsible for some of their major side effects. See Chapter 15. Figure 318 illustrates the proposed mechanism of action of the conventional antipsychotics, which include the phenothiazines, thioxanthines, butyrophenones, and pharmacologically related agents. As summarized in Figure 319, many of the untoward side effects of these drugs can be understood as a logical extension of their receptor blocking activity. Because dopamine in the basal ganglia plays a major role in the regulation of movement, it is not surprising that dopamine blockage can lead to motor abnormalities, extrapyramidal side effects, such as Parkinsonism, akinesia, akathisia, dyskinesia, and tardive dyskinesia. Nurses and physicians often monitor patients for evidence of involuntary movements after administration of the conventional antipsychotic agents. One popular scale is called the Abnormal Involuntary Movement Scale, or AIMS. Chapter 15 provides an example AIMS and a discussion of clinical use of antipsychotic drugs, side effects, specific nursing interventions, and patient teaching strategies. An important physiological function of dopamine is that it acts as the hydrothalamic factor that inhibits the release of prolactin from the anterior pituitary gland, so blockage of dopamine transmission can lead to increased pituitary secretion of prolactin. In women, this is hyperprolactinemia. That can result in amenorrhea, absence of the menses, or galactorrhea, breast milk flow. In men, it can lead to gynecomastia, development of the male mammary glands. Acetylcholine is the neurotransmitter released by the postganglionic neurons of the parasympathetic nervous system. Through its attachment to the muscarinic receptors on internal organs, it serves to help regulate internal function. Blockage of the muscarinic receptors by phenothiazines and a wide variety of other psychiatric drugs can lead to a constellation of untoward effects, which are predictable based on knowledge of the normal physiology of the parasympathetic nervous system. These side effects usually involve blurred vision, dry mouth, constipation, urinary hesitancy. These drugs can also impair memory, since acetylcholine is important for memory function. Figure 318 shows how the conventional antipsychotics block dopamine receptors. Figure 319 is a graph or a concept map of adverse effects of receptor blockage of antipsychotic agents. In addition to blocking dopamine and muscarinic receptors, many of the conventional antipsychotic drugs act as antagonists at the A1 adrenergic receptors for norepinephrine. These receptors are found on smooth muscle cells that contract in response to norepinephrine from sympathetic nerves. For example, the ability of sympathetic nerves to constrict blood vessels is dependent on the attachment of norepinephrine to A1 adrenergic receptors. Blockage of these receptors can bring about vasodilation and a consequent drop in blood pressure. Vasoconstriction, mediated by the sympathetic nervous system, is essential for maintaining normal blood pressure when the body is in the upright position. Blockage of the A1 adrenergic receptors can lead to orthostatic hypotension. The A1 adrenergic receptors are also found on the vas deferens and are responsible for the propulsion contractions leading to ejaculation. Blockage of these receptors can lead to a failure to ejaculate. A1 adrenergic antagonists with little anticholinergic effects, such as trazodone, can lead to priapism, secondary to the ability for detumensis, which is subsistence of erection. Finally, many of these conventional antipsychotic agents, as well as a variety of other psychiatric drugs, block the histamine 1 receptors for histamine. The two most significant side effects of blocking these receptors are sedation and substantial weight gain. The sedation may be beneficial in severely agitated patients. Non-adherence to the medication regimen is a significant issue because of these troublesome side effects, and the atypical antipsychotic agents have consequently become the drugs of choice. Now, so I guess we'll talk about the atypical antipsychotics. The second generation of antipsychotic drugs includes the atypical antipsychotics, which produce fewer extrapyramidal side effects, EPS. And they target both the negative and positive symptoms of schizophrenia. See Chapter 15. These newer agents are often chosen as first-line treatment over the conventional antipsychotics because of their lower risk of EPS. However, 5 of the 7 available atypical antipsychotics can increase the risk of metabolic syndrome with increased weight, blood glucose, and triglycerides. The simultaneous blockade of 5-HT2C and histamine 1 receptors is associated with weight gain due to increased appetite stimulation via the hypothalamic eating centers. Strong anti-muscarinic properties at the M3 receptor on the pancreatic beta cells can cause insulin resistance, leading to hyperglycemia. The receptor responsible for elevated triglycerides is currently unknown. Clozapine and olanzapine have the highest risk of causing metabolic syndrome. Aripiprazole and ziprasidone have the lowest risk. The atypical antipsychotics are predominantly dopamine and serotonin antagonists. The blockade at the mesolimbic dopamine pathway is thought to decrease psychosis, similar to the mechanism by which the conventional antipsychotics work. Decreasing dopamine can reduce psychosis but cause adverse effects elsewhere, such as the movement side effects of EPS, the worsening of cognitive and negative symptoms, and an increase in the hormone prolactin. Excuse me. Leading to gynecomastia and galactorrhea, amenorrhea, and low libido. Comastia. Clozapine or clozaril. The first of the atypicals is an antipsychotic drug that is relatively free of motor side effects of the phenothiazines and other atypical antipsychotics. It is thought that clozapine preferentially blocks the dopamine receptors in the mesolimbic system, rather than those in the nigrostriatal area. This allows it to exert an antipsychotic action without leading to difficulties with EPS. Although people who take clozapine are more likely to adhere to their medication regimen than those who are taking other atypical antipsychotics, it can cause a potentially fatal side effect in up to 0.8% of patients. Clozapine has the potential to suppress bone marrow and induce agranulocytosis. Because any deficiency in white blood cells renders a person prone to serious infection, regular measurement of white blood cells count is required. Typically, the count is measured weekly for the first 6 months, every other week for the next 6 months, and monthly thereafter. However, new research indicates that it is medically justifiable to discontinue blood counts after 6 months if a knowledgeable patient does not want them, especially if adherence is jeopardized. Clozapine has the potential for inducing convulsions, a dose-related side effect in 3.5% of patients. Caution should be used with other drugs that can increase the concentration of clozapine. There is also a potential for myocarditis that should be monitored, but the most common side effect of clozapine are drowsiness and sedation. 39% hypersalivation, 31% weight gain, 31% weight gain. I'm not sure what these percentages mean. 31% reflex tachycardia, 25% constipation, 14% and dizziness, 19%. Whatever. Risperidone has a low potential for inducing agranulocytosis or convulsions. However, high therapeutic doses, greater than 6 milligrams a day, may lead to motor difficulties. It has the highest risk of EPS among the atypical antipsychotics and may increase prolactin, which may lead to sexual dysfunction. Risperidone can cause orthostatic hypotension that can lead to falls, which are a serious problem among older adults. Weight gain, sedation, and sexual dysfunction are adverse effects that may affect adherence with the medication regimen and should be discussed with patients. It is notable that risperidone is the first atypical antipsychotic available as a long-acting injection. Risperidone Consta, administered every 2 weeks, provides an alternative to the depot form of conventional antipsychotics. A rare but serious side effect is an increased risk of cerebrovascular accidents in older adults with dementia who are being treated for agitation. Quetiapine, or Seroquel, has a broad receptor binding profile. Its strong blockage of histamine 1 receptors accounts for the high sedation. The combination of histamine 1 and serotonin receptor blockage leads to the weight gain associated with use of this drug and also to a moderate risk for metabolic syndrome. It causes moderate blockage of A1 adrenergic receptors and associated orthostasis. Quetiapine has a low risk for EPS or prolactin elevation from low D2 dopamine binding due to rapid dissociation at these receptors. Other atypical antipsychotics include olanzapine, Zyprexa, ziprasidone, Geodon, aripiprazole, Abilify, and paliperidone, and Vega. Olanzapine is similar to clozapine in chemical structure. Side effects include sedation, weight gain, hyperglycemia with new onset type 2 diabetes, and higher risk for metabolic syndrome. Ziprasidone is a serotonin norepinephrine reuptake inhibitor. The main side effects are dizziness and moderate sedation with a known history of QT interval prolongation, recent acute myocardial infarction, or uncompensated heart failure. Aripiprazole is a unique atypical antipsychotic known as a dopamine system stabilizer. In areas of the brain with excess dopamine, it lowers the dopamine level by acting as a receptor antagonist. However, in regions with low dopamine, it stimulates receptors to raise the dopamine level. It has little sedation and weight gain. Side effects include insomnia and akathisia. Paliperidone, the newest antipsychotic in the United States, is the major active metabolite in risperidone. It has similar side effects such as EPS and prolactin elevation. Its side effects are orthostasis and sedation. The osmotic release oral system, or OROS, provides consistent 24-hour release of medication, leading to minimal peaks and troughs in plasma concentrations. Chapter 15 discusses the conventional and atypical antipsychotic drugs in detail, including the indications for use, adverse reactions, nursing implications, and family and patient teaching. Drug treatment for attention deficit hyperactivity disorder. Children and adults with attention deficit hyperactivity disorder, ADHD, show symptoms of short attention span, impulsivity, and overactivity. Paradoxically, the mainstay of treatment for this condition in children, and increasingly in adults, is the administration of psychostimulant drugs. Both methylphenidate, Ritalin, and dextromethamphetamines, such as Adderall, seem to show efficacy in these conditions. They are sympathomimetic amines and have been shown to function as direct and indirect agonists at adrenergic receptor sites. Psychostimulants act directly at the postsynaptic receptor, mimicking the effects of norepinephrine and dopamine into the presynaptic neuron, and increase the release of these monoamines into the extraneuronal space. How this translates into clinical efficacy is far from understood, but it is thought that the monoamines may inhibit an overactive part of the limbic system. Among many concerns with the use of these drugs are the side effects of agitation, exacerbation of psychotic thought process, hypertension, and long-term growth suppression, as well as their potential for abuse. One non-stimulant medication available for the treatment of ADHD is atomoxetine hydrochloride, or Strattera, a norepinephrine reuptake inhibitor approved for use in children 6 years and older. Common side effects include decreased appetite and weight loss, fatigue and dizziness. Refer to Chapter 28 for more on these agents. Drug treatment for Alzheimer's disease. The insidious and progressive loss of memory and other higher brain functions brought about by Alzheimer's disease is a great individual, family, and social tragedy. Because the disease seems to involve progressive structural degeneration of the brain, there are two major pharmacological directions in this treatment. The first is to attempt to prevent or slow the structural degeneration. Although actively pursued, this approach has been unsuccessful so far. The second is to attempt to maintain normal brain function for as long as possible. Much of the memory loss in this disease has been attributed to dysfunction of neurons that secrete acetylcholine. Tacrine and donepezil are anticholinesterase drugs, also called cholinesterase inhibitors, that show some efficacy in slowing the rate of memory loss, and in some patients may even improve memory. The drugs work by interfering with the action of acetylcholinesterase. Inactivation of this enzyme leads to less destruction of the neurotransmitter acetylcholine, and therefore a higher concentration at the synapse. There are 5 agents FDA approved for the treatment of Alzheimer's disease in the United States, 4 of which are acetylcholinesterase inhibitors: Tacrine or Cognex, donepezil or Aricept, galantamine or Remenil, and rivastigmine or Exelon. Among the acetylcholinesterase inhibitors, tacrine is no longer used extensively because of the risk of hepatic toxicity in some patients. The 5th agent approved by the FDA for treatment of Alzheimer's disease is memantine or Namenda, a non-competitive N-methyl D-aspartate or NMDA receptor antagonist. The glutamatergic neurotransmitter system plays an important role in memory formation. Amyloid plaques in the brain can lead to glutamatergic dysfunction and excess glutamate. When glutamate binds to NMDA receptors, calcium flows freely from the cell. Overexposure to calcium results in cell degeneration. Memantine fills the NMDA receptor sites and reduces this degeneration. Memantine was shown to be effective in the treatment of moderate to severe Alzheimer's disease. Refer to Chapter 17 for a more detailed discussion of these drugs, as well as their nursing considerations and patient and family teaching. Herbal treatments. Excuse me. The growing interest in medical herbs is driven by a variety of factors. Many people believe that herbal treatments are safer because they are natural, or that they may have fewer side effects than more costly traditional medications. Herbal treatments have been researched in efforts to understand their mechanisms of action. They have also been studied in clinical trials to determine their safety and efficacy. This is especially true of kava kava and St. John's wort. Some medicinal herbs have been found to be non-therapeutic, and others even deadly if taken over long periods of time, or in combination with other chemical substances and prescription drugs. The risk of bleeding may be increased in patients taking ginkgo biloba, and warfarin, and kava kava may increase the risk of hepatotoxicity at doses over 240 milligrams per day. Among the major concerns of healthcare professionals are the potential long-term effects of some herbal agents, nerve, kidney, and liver damage, and the possibility of adverse chemical reactions when herbal agents are taken in conjunction with other substances, including conventional medications. St. John's wort can have serious interactions with a number of conventional medications. Taking St. John's wort with other serotonergic agents, e.g. SSRIs and triptans, can cause serotonin syndrome. And it may also reduce effectiveness of other medications by increasing their rate of metabolism and reducing blood levels of these medications. St. John's wort is a cytochrome P450, CYP450, 3A4 enzyme inducer. Patients taking CYP450 3A4 metabolized medications, e.g. oral contraceptives, digoxin, theophylline, some immunosuppressives, concurrently with St. John's wort may experience increased metabolism and subtherapeutic drug levels. Another key concern regarding the use of alternative herbs and nutrients is the quality of herbal supplements on the market. Many brands are of poor quality, have dosing inconsistencies, or are questionable, or are of questionable purity or stability. This is partly because herbal preparations are sold as dietary supplements rather than drugs. Thus, they avoid regulation under the FDA's Federal Food, Drug, and Cosmetic Act. Healthcare professionals and especially nurses need to stay current, using unbiased sources of product information and passing this information on to patients taking alternative agents. Independent evaluation of many brands with updates can be found at www.consumerlab.com or blah 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 blah. It is important that nurses and other healthcare professionals explore the patient's use of herbal supplements in a non-judgmental manner by asking, what over-the-counter medications or herbs do you take to help your symptoms? Do they help? How much are you taking? How long have you been taking them? Individuals taking medications or other supplements should be made aware of drug-substance interactions and product safety. Such discussion should be part of the initial and ongoing interviews with patients. Chapter 36 covers complementary and integrative therapies in more detail. Key points to remember. Excuse me. All actions of the brain, sensory, motor, and intellectual, are carried out physiologically through the interactions of nerve cells. These interactions involve impulse conduction, neurotransmitter release, and receptor response. Alterations in these basic processes can lead to mental disturbances and physical manifestations. In particular, it seems that excess activity of dopamine is involved in the thought disturbances of schizophrenia, and deficiencies of norepinephrine, serotonin, or both underlie depression and anxiety. Insufficient activity of GABA also plays a role in anxiety. Pharmacological treatment of mental disturbances is directed at the suspected neurotransmitter receptor problem. Antipsychotic drugs decrease dopamine, antidepressant drugs increase synaptic levels of norepinephrine and or serotonin, and anti-anxiety drugs increase the effectiveness of GABA or increase 5-HT and or norepinephrine. Because of the immediate target activity of a drug, can result in many downstream alterations in neuronal activity. Drugs with a variety of chemical actions may show efficacy in treating the same clinical condition. Thus, newer drugs with novel mechanisms of action are being used in the treatment of schizophrenia, depression, and anxiety. Unfortunately, agents used to treat mental disease can cause various undesired effects Prominent among these can be sedation or excitement, motor disturbances, muscarinic blockage, antagonism, sexual dysfunction, and weight gain. There is a continuing effort to develop new drugs that are effective, safe, and well tolerated. Any NCLEX on here? Nope, that's it. That was chapter 3 of Varcarolis.